What I want to do is probably start with a question that was raised during the presentation about the finance from the gentleman on my right here, and about can we afford to staff all the A&E departments with consultants 24/7. I think if I remember rightly, that was the gist of your question. Is that right?
Given that Forbes Watson said at a previous meeting, Forbes Watson, for the audience, is the chairman of the Clinical Commissioning Group, that the government are looking to cut another £30 billion out of the health service. And the reason that you're looking, you've got the clinical service review, by the sound of it, is mainly because we won't have enough money. What you're describing looks as though it might be more expensive than it is at the moment. So it just doesn't seem to gel. Sounds good, but...
Okay, so where we are in terms of, there is clearly financial pressure. So, and I think as Chris showed in his slide, we forecast around about 200 million. If we continue to work the way we're working, that's the way GPs work, the way hospitals work, the way the communities work, we will have a deficit of £200 million. And as part of the role of the CCG is how do we get balance back into the services and the funding. So we have a funding envelope. The 30 billion is about adding all of those numbers together to give what the future spending of the NHS is. And I think what Simon Stevens has presented is a 5-year forward view from the NHS, which says we can close all of that by efficiency savings and changes of ways of working, but still does leave an 8 billion gap. There is an efficiency. There are efficiency savings to be made. There are absolutely efficiency savings to be made. And what we've seen so far in the review, there are some things that are duplicated, but they're duplicated sub-effectively. So we've got two things running, neither of which works particularly well. So there are definitely things that we can do. We've got a challenge that effectively the growth of our costs is about 4% per year, and the money from government goes up only 1% per year. So we've got a difference between those two numbers. So so the finance is a key part, and how we're dealing with that is we've got the clinical working groups, which I've talked about, deal with what is the right clinical model. Then we've got all of the finance directors and chief operating officers from all of the hospitals and the community trusts saying, what is our current baseline cost, what is affordable? And we've got the chief execs working together to say, how are we going to make this work? And we're pulling all that together in the review. So it's a balance between what is affordable and sustainable with what services are available. But we've also got the need to drive improved quality. And that's why the green, yellow and purple bit helps us think about what that hospital looks like. So there is an affordability question, but affordability is about sustainability. There are some cost savings that absolutely cost savings can be made. There are different ways of spending our money, that's absolutely clear. And also there are different ways of working which reduce the cost of providing some services. So we can provide services in a different way, there are lower costs. So all of that together is in the review. As I stand here today, I don't know what the numbers look like because we're working through that right now. And that's what we'll have. When we come to consultation, we will have we'll have all the finance with the clinical models together. So we'll be coming out with, this is what our affordable options are. So that's our intent.
But what if the new government decides to put lots more money into the NHS, given that the UK spends less on NHS than most other European countries? Would that stop you going ahead, or?
I'd be speculating as to what difference that would make, because as I say, I don't have the baseline numbers to do that. But what I would say is there are challenges in quality, and they need to be addressed anyway. I think our fundamental tenet is we're starting with the population of Dorset and saying, what do they clinically need? I think it may change what the amount of something, it could change that, but I'd only really be speculating. But at the moment, money is not the only answer.
Not the only problem.
It's not the only problem, or the answer. Right, yeah, thanks very much.
I've been asking this question both of DHUFT and of the CCG for a little while now, due to the changes in, I'm sorry to bang on mental health services, but overall my question to them is who actually is responsible for designing the new service that has been a complete disaster over the last 2 years, and who is going to be responsible for I keep hearing about we're gathering information, we're doing models, we're doing this, but you can never find out who is actually responsible for designing what we are going to be stuck with.
Can I just are you talking specifically about mental health services or about all the services?
I'm talking about all the services because the answers that I get currently from DHAFT is that we just put into place what the CCG designs, and from DHAFT, the person I spoke to, sorry, from the CCG, the person I spoke to said, we don't design the service, we just commission it. So the question is, who blimmin' well is designing it?
I would hope that what we've shown today is that actually we're collectively redesigning the service.
Sorry, I don't get that. You're carrying out activities at some point will result in changes, but there's the bit in the middle as to who is actually responsible. So there doesn't seem to be any accountability for disasters that have happened in the past.
Okay. The final decision after the public consultation period, when we go out with the various models of care, the final decision will be taken by the governing body of the CCG. And it is that decision then which will move forward into the implementation phase.
So it is your part of the CCG that is going to be responsible for the design of what we end up with?
We will be responsible ultimately for taking the proposals, the models, that then go out to public consultation to bring back the views from the public through the public consultation to finally say, well, okay, out of these X number of models, be it 3, 4 or whatever, for in-hospital, out-of-hospital care, all of that, then actually we will be taking forward for implementation these models. Now, we can't say it's going to be one model, because hopefully we've shown that one model will not fit every scenario in Dorset.
Still not, you could be a politician, you're still not answering my question. So given that you are creating the models, I don't mean you personally, I mean your group is creating the models, okay, they're going out to public consultation, and you may tinker with them or whatever, but so it is your group. I just want a yes or no. Are you responsible for the design?
We are leading the design.
So you're not responsible for it?
No, okay. Yes, we are. We're responsible for making the decision. We're responsible for making the final decision of what goes forward for an implementation. But, you know, yes, we could sit in a closed room as a CCG and design the models. We could do that. And as I said in my bit of the presentation, in 30 years NHS experience, that is what has happened in the past. People have got into rooms, politicians, managers, others have got into closed rooms and designed a model, come out and saying we're doing that. What we're trying to do is say we need to lead the process, but actually we have to take the views of the widest range of people within the service, associated with the service, and users of the service as to what that design will look like. But ultimately, when it comes down to saying, we have a choice between Model A or Model B, and I'm not saying we will have one model, but we have A and B in September that's gone out to consultation, and people have said, actually, Model A and Model B, we can't, you know, it's one or the other, then the CCG and its governing body will say, right, we go with Model A.
So I will take that the CCG, despite saying they're not responsible for the design, in this instance will be responsible for the design.
I don't know who said at the CCG that we're not responsible. We are engaged in the design and we're responsible for the final decision.
I'm not talking about now, I'm talking about in the past. That's what's been said for some truly horrendous decisions that have been taken that ended up with me being stabbed, so I have a personal interest in this. What I'm saying is the next set of stuff that we are going to get given, we need somebody to say, I am responsible for that design, because I feel until you start taking responsibility for this, or somebody does, we're never going to reach a solution.
And I'm sorry to hear of your personal experience, and I think, you know, that obviously impacts on all of us in terms of how we react to things. I can't make excuses for what's happened in the past. All I can do here and now is say, looking at the future and what we're going through, we want it to be different. And yes, we have to take responsibility. At the end of the day, the CCG will make a decision based on what we're going through now and the public consultation, and it will make a decision. These are the models of service that we want that we're going to actually lead on implementing in Dorset.
I'll take that as a yes then.
Yeah, I mean, personally, you're asking me for a personal response on behalf of a corporate organisation. I'm sorry if I sound like a politician. I'm happy to do that. You know, as a clinician, in 30 years working with patients, if you were my patient, I would take personal responsibility. And if I made a wrong decision, I'd come and apologise to you. But unfortunately, we're in a corporate world. I'm happy to do it.
Sorry, in a corporate world, in business outside of the NHS, you still have personal accountability.
Just very briefly comment. I'm Simon Watkins, I'm a GP. I think what Chris is trying to say is yes, as a CCG, we will take responsibility for coming to a decision at the end. But the road to get to that decision is to get everybody's opinion and everybody's involvement so that when we make that decision receives the support of the wider public.
Just going back to the first question, I'll be very quick because don't want you to repeat yourself, but what you've told us today seems like fantastic blue sky thinking, all of which looks very, very optimistic, and to my mind, and I think to others in the audience, only looks like it's going to cost more money. What I'm really interested in is how you're going to make the cost savings, and you seem to have really brushed over that, and I know that's what most people in Dorset that know this, that understand the situation financially, you know, that it's where the cost savings are going to come and how that's going to bite and adversely affect people.
I don't know the answer to the question where the cost savings will actually come from. I know because we're not that far into the work. What we've done here is to say what clinically is the right thing to do. What the finance teams are working on is what's affordable. The challenges we've had in the past is the individual parts of the NHS have been asked to save in their own individual right. And actually in Dorset, certainly from a hospital point of view, we're doing much better than the UK average in terms of driving out waste and driving out duplication and driving out unnecessary paperwork and driving out, and that's benefited because that money's been reinvested in the services and the staff and the development and all of those things. So that's been a really good thing.
I just want you to be honest, because this is a really, really optimistic presentation, and I wouldn't like people to just go away thinking, oh, all these fantastic things are going to happen. We're going to have consultants 24/7, and you've just not touched at all on what you're looking at that could possibly save you money. I mean, I don't necessarily want you to answer that further, but it's just an opinion. Because I want you to have time for other people's questions.
I recognise that. So that's what we'll be doing in the consultation. We'll be saying, this is what the clinical model looks like, this is what's affordable, these are the different ways we could organise ourselves to make it work. But we do know things, for example, I'll give you one example. We have a huge amount of money invested in buildings. So we have a huge amount of money invested in buildings, and they're very expensive to run. So Chris gave you the number, is about $500,000 for the hospital, 500 million for the hospitals, and just under half of that is just doing the buildings. So just keeping all that going, but we don't use them all the time. So there are some things which as well, is there a better way of using them? Or could we deliver the services somewhere else, which means we don't have to maintain this building and actually put the investment in the service rather than in the maintenance? There's some of those sort of things. We're going to do it at a Dorset-wide level though, and that's not been done before, and that gives us the flexibility. But we won't be coming out to say to you, this is what we're going to do, unless we can show what the financial costings are and how we're going to do that.
Yes, I'm Peter Blick, I'm a GP. I think we've looked at evidence from up and down the country on where more efficient delivery of services can occur. And I think a lot of the savings that we can make can come out of that evidence from elsewhere. Slightly different models of care, delivering care nearer people's homes, delivering care in people's homes can produce cost savings. And so we have looked at that evidence, and there's a great folder. I think Phil is probably one of the few people to have completely digested the folder. Is it about 150 pages, isn't it, of evidence and most of us have gone through it. But there is considerable evidence from other parts of the country, from other parts of Europe, where we can make cost savings. And I'm totally, having read all that evidence, I, for one, I'm convinced that we can actually make appropriate cost savings.
All of the organisations have they have absolutely now the mandate to reduce their costs. So nobody's waiting for, so if there is feedback, we should just feed that in. What we're doing is, because we've got to look at the whole system, so at a really simple level, you take 2 GP practices, they're both filling in forms. If they collaborated at an administration level, they get half the number of forms they filled in. So there are some things there's some even basic things like that we could do. But we need to drive that forward, and CSR gives us an opportunity to look at the total amount we spend on healthcare in Dorset is £1.2 billion. And other, as Peter said, there are other health economies in the country which for certain aspects have reduced cost by up to 30% or 40% without actually having any impact on the service. And we could do, that's our opportunity with CSR. So there are savings at the moment. The hospitals have a continual improvement plan to reduce their costs. They run that year on year, and they're under a Monitor, which is an central government organisation which monitors that. So we have those things in place. But if there are, so we're very happy to take ideas. But the overall plan is to reduce our cost base across the piece and reinvest that money in the services we've talked about today.
And some of the services are already pared down to nothing. So nothing less nothing is still nothing.
And that's why we're not looking at individual services to begin with. We're looking at how we approach the models of care. Because there are definitely different ways of working which change what the cost base is for a service.
Where are you going to get the extra clinical staff from?
Well, that's going to be a challenge. I mean, we touched on workforce. But perhaps to address it specifically, we are aware there are not enough doctors, there are not enough nurses for the current models of care. I mean, Phil, when he was talking about A&E services, for example, there are some recommendations for the number of A&E consultants that should be in one A&E department covering a certain population. Currently, none of our 3 acute hospitals meet those standards. But if you took all the 3 A&E departments in Dorset, with all the consultants working in them, there are enough, but not to cover 3 sites.
What about the distance involved, though? If you're going to have to come from Dorchester to Poole, you know, how are you going to get, I mean, how are people going to access that
Well,
care?
first of all, there's no decision made about which. Secondly, and part of the answer Francis touched on in the big ask, that, you know, some of the responses we got there was that people are prepared to travel if it is necessary to get the highest quality care.
You're talking about emergency care, are you not? Or am I wrong?
Yeah, but there is different levels of emergency care. Hence, Phil's slide with the different 3 colours of hospital. And I would add into that, that's just the hospitals. If you're looking at what happens in the communities, is different still. But already, if somebody has a real major trauma with multiple fractures, multiple internal injuries, they already go to Southampton. They don't stay in Dorset. Now, they're very small numbers.
Do they go straight to Southampton, or do they go to Poole?
They go straight to Southampton. The Ambulance Trust knows that if a person has that serious an injury and needs such intensive multidisciplinary care, the policy now, the rule now is that they go to Southampton. Southampton is a designated real major trauma centre for the central southern belt.
By ambulance or by helicopter?
By the quickest way they can get there, if it's helicopter or ambulance. But below that, the report which defined all of this describes the next level of hospital and the next level of care that people should receive for the next level of need. And currently, we don't have that in Dorset, in none of our 3. So if we're going to look at that, and we're looking at what should exist in Dorset, we have to say, we need something like that, and where is that going to be? But those people, you know, they're not the people who walk into A&E, they're still the people with major trauma who get, you know, transported by ambulance and real illness, but not necessarily that high level that needs to go to Southampton. And for those people, then maybe we just need one centre in Dorset. But below that will then be people who need emergency care, but perhaps not all the support services around. and maybe that could be at 2 or 3 locations. And these are the sort of models that we're discussing about. And ultimately, it would be people, because a lot of A&E attendances currently are people who walk in with actually conditions that could be much better managed within the community and close to their home.
Very little has been said about patients in your presentations this morning, which was interesting. I know they're a blinking nuisance. My main point is there's also nothing about education in your presentation. And we've heard over this past winter that people are turning up at A&E with colds. They're turning up at GP surgeries with colds. Is it not time that young people are educated about looking after their children at home, giving them whatever it is you give them these days, and how to deal with a wound when the child has fallen over? I mean, they don't do it anymore, and I think it's very sad that they don't do it, but is it not time that perhaps young women who are pregnant are given a proper education, you know, how to look after your child? Am I being simplistic?
I mean, first of all, personally, it's difficult to talk about patients, because if you, in other forums, patients is a no-no word, it's clients and everything else. But, you know, we're all patients at some stage in our life with the healthcare service, but so let us talk about people who aren't just recognised patients who do attend, who have a condition, but the public who don't routinely go to the healthcare services. And that hopefully will include everybody. Secondly, I mean, personally, I think you're spot on. I think one of the problems nowadays is with the demand is that the younger families with the dispersed family support network is creating a demand at a lower level of need, but unfortunately we still have to respond to that. And there's one group of thought that people have looked at trying to educate these families and individuals to use healthcare services better, and actually that is almost a generational thing that you need to do to actually change behaviour patterns. And I think we do need to take that on board. And hopefully in some of our preventative work, there's the 2 aspects. People with conditions, illnesses, are helped to manage and care for themselves better at home, themselves, with their immediate family and other agencies. And those people who, like you're describing, actually in time, the repetitive young mum who takes their kid to A&E with every cough and cold, and at a meeting last night I was hearing about a young GP who saw a coryzal child 5 times in 2 weeks. You know, slowly we can get that behaviour pattern changed. Looks like Phil wants to answer us.
Absolutely, prevention is a key part to come out of some of the groups, and the patient is centric. So the whole review starting out with 750,000 people. So we started with that. We didn't start with anything else. That was what we started with. I think in terms of our timing today, we have time for one last question.
Graham Downer, a patient who's been to quite a few of these meetings. I jotted down a comment of yours, Chris, from fairly early in your introductory talk. You said bringing care closer to home was a phrase which you'd heard pretty frequently over the course of 30 years. Now, it does strike me, first of all, that there's going to be a cost to bringing care closer to home, and it could turn out that that will be more expensive than the cost of continuing to have people visiting hospitals. But also, it strikes me that there must be a reason why, to take up your further comment, in spite of it being mentioned over those 30 years, it's never actually happened. And it may be, I wonder what reason there is for being more hopeful about achieving it now than during the past 30 years. So perhaps a comment on that, please.
Right, thank you. I shall try and be very brief in this one. I'm optimistic. I mean, I've said this before at another meeting. You know, I have retired from clinical practice 2.5 years ago. In some respects, I wish I hadn't now. And the reason being that statement was often made, but what didn't follow were the organisational changes to actually make it happen. yes, you're quite right, the care may be more expensive, and we need to be very conscious of that. But the reason I think it's not happened up to now is because when there is ever any additional money in the healthcare system or any additional investment, the gravitational pull always seems to be into the acute sector, historically. And, you know, relatively, community services have actually been underfunded. Phil mentioned a 4% growth in costs per year. That 4% growth is driven by the need of the acute sector. If you look in the community sector, many of the funding streams have actually virtually been flat cash for the last 5 or 6 years. And one thing I would hope that comes out of this clinical service review, personally, for my colleagues who are still working in general practice and all my other colleagues who are working in the community, is that for once, actually, resources are shifted, are truly moved to support those community services. Because at the end of the day, the acute trust can't survive unless we do more in the community to release the time and space for them to do their specialised care.
Last year there was a proposal for some services between Bournemouth and Poole hospitals to be amalgamated or readjusted to the benefit of the hospital and perhaps to the slight inconvenience of some of the patients. That was scuppered by the Competition Commission. Now, what assurances would you have in implementing your options that they will not be similarly screwed up by the Competition Commission? It appears to me as a layman that competition is inappropriate in the National Health Service and collaboration and cooperation is much more effective.
Let me address those 2 points. The first thing is the CMA did block it was the merger of Poole and Bournemouth hospitals into one, so that did block. There is a current undertaking that is in force right now. So as part of our discussions with the CMA, it will be about what is realistic and what's not realistic about what we do about services. I think the difference is we're focusing on the service rather than they were focused on the hospital. So what's been blocked is a merger of the two hospitals. So that may or may not be a problem, but we've opened that dialogue, so that's absolutely right. The thing about competition is law. We have to, by law, go out to competitive tender for services that we identify that we want to commission. So our role as a commissioning organisation is to say, this is the service to this quality, and then we have to, by law, go out to tender for that. If the law changes, then that would address... Sorry? Best change the law. Right. Obviously, I can't comment particularly on the law, but what I can say is that competition... The NHS need to compete, need to create a competitive landscape because that's how the law currently stands. So we have to comply with the law. Well, what's interesting is that competition doesn't mean privatisation. So at the moment, if we have a service, the hospitals compete. NHS hospitals compete between each other to win that service. GP practices or groups of GP practices compete to win that service. So competition is not about privatisation, it's about competition. We have less than 5% of our money in Dorset spent on non-NHS organisations. And our plan for CSR is not about, we don't have a privatisation agenda. We do have a legal requirement to go to tender.
My primary interest is in mental health care. However, I used to work at a clinic in Madrid, and the doctors there used to have diet sheets for patients. It's a very basic sort of thing. And I really do think, I've never heard of a patient being given a diet sheet in this country by their GP when they're beginning to gain weight at the beginning of their weight gain. And I think it would be very, very helpful. Because this week we've been in Salisbury Hospital and it was full of really, really heavy people. Very young people to very old people. I was horrified. The other thing is there's a big void in North Dorset for mental health. There is a property not far away from us in Shaftesbury, which I feel could be utilised in a much more effective way, but it's something I need to talk, or we need as a carers group, to talk to someone about from the CCG to put our ideas. The other thing is we really drastically need someone who can be on the end of a phone 24 hours a day, or even just during the night would help, because there are the mental health surgeries, to speak to people who maybe they can prevent from becoming very ill, or at least keep them going until they can get hold of the crisis team or the surgery in the morning.
Prevention, we have acknowledged we do need to do much more about. And you know, I am aware in my own practice we did used to have diet sheets available, but again, that comes back to some of the variability that we touched on. But prevention is a big profile of what we're at. The more specific questions about the mental health services in North Dorset, yes, we need to hear your experiences, and we need to respond to those. So please, you know, keep us informed. The ideas about use of facilities, again, we want to hear what your views are. I mean, at the risk of sounding like a politician, I can't promise, we can't promise here, but we need to hear your views. If you have really valid views about how to use services and facilities in your community much better than they're being used,
without spending a fortune,
well then we'd really appreciate those views. You know, and we're prepared to listen to them.
Yes, you've been talking about all these models you're working on, and there is a new department in NHS England for new models with a new recent director. Are the models you're working on, are they similar, or do they come from NH England New Models Department?
Yeah, so we're working with Sam Jones on the models of care. So this is the 5-year forward view you might have heard, those of you might have heard from the NHS, which lays out how the 5 years for the NHS should go. The models of care are absolutely being incorporated, so we're using, we're using those models.
Thank you very much, everybody. Just to repeat, if you do have thought of questions that you haven't managed to get round to, or questions that subsequently come out in your thoughts, if you're like me, you'll go home and driving home and get home and have a cup of tea and you'll think of something, oh, I wish I'd have asked. Please, there are numerous ways you can contact us. Francis has kindly put up the slide showing the various ways. If it's on your way out, there's a suggestion box to pop in. There's the various electronic ways, or there's just a plain telephone number. But please, we do want to hear your views and your questions. But thank you very much for coming today, and have a safe journey home.